Hello and welcome to today's webinar, Homozygous Familial Hypercholesterolemia Across the Lifespan, Understanding and Disease at different stages of life. This webinar is presented by International Atherosclerosis Society and is co-hosted with the Gulf Association of Endocrinology and Diabetes, the Middle East and North Africa Pediatric Endocrinology and Diabetes Society, and the Saudi Heart Association Atherosclerosis Working Group. The event is sponsored by Gen Farm. I am Fahad Al-Nouri, and I am pleased to welcome you to this important webinar about homozygous familial hypercholesterolemia. On screen, you can see our agenda for today. We have some fantastic lectures from experts. Then we will have the time for discussion and to answer some questions from the audience. It's fitting that we come together today on Homozygous Familial Hypercholesterolemia Awareness Day to talk about this rare, severe genetic disorder. It causes extremely high LDL cholesterol and can lead to premature atherosclerotic cardiovascular disease, heart attacks, and even death, sometimes as early as childhood. Given these dire outcomes, there is a tremendous need for education about homozygous familial hypercholesterolemia, and we have a fantastic program to do just that. On the screen here, you see the program for today. But before we start the lectures, I'd like to introduce myself and my fellow moderators. I am Fahad Al-Nouri, and I am on the board of director of the International Atherosclerosis Society. Here in KSA, I am the head of the cardiovascular prevention unit at the Prince Sultan Cardiac Center, Riyadh, where I dedicated much of my time to diagnosis and treating familial hypercholesterolemia, an underdiagnosed and undertreated disease which has a high prevalence in Saudi Arabia, where the consanguinity is widespread practice and estimated to be around 55%. Unfortunately, Nasreen Al-Sayed has had a situation arise and won't be able to join us today. Now, I'd like to introduce our other two moderators who will participate in the discussion after our expert lectures. First, Professor Asma Deeb is Chair of Pediatric Endocrinology at Sheikh Shakhbout Medical City in Abu Dhabi, United Arab Emirates, and she's also the chair of the Research Ethics Committee at the SSMC and the clinical professor at the Gulf University and Khalifa University, UAE. Professor Deeb is the president of the Middle East and North Africa Pediatric Endocrinology and Diabetes Society. Professor Deeb has held various international senior positions in pediatric endocrinology, including executive board member at the International Consortium of Pediatric Endocrinology, Chair of Communication in the European Society of Pediatric Endocrinology, and an advisory board member in the International Society for Pediatric and Adolescent Diabetes. Also moderating with us today is Tariq Al-Had. Dr. Tariq Al-Had has extensive experience in the internal medicine, diabetes, and endocrinology, working in the UK, Saudi Arabia, and Sudan, and has been with Hamad Medical Corporation since 2014. Dr. Al-Had has published as author or co-author of over 100 papers in peer-reviewed journals. He is currently president of the Gulf Association of Endocrinology and Diabetes, treasurer of the Arab Thyroid Association, and convener of the Gulf Pituitary Forum. On screen, you see all four of our expert speakers who will each be introduced in turn ahead of their lecture. I'd like to introduce our first speaker, Nando Thalang. Professor Nando Thalang is a consultant pediatric endocrinologist at Genesis Health Center in Dubai and clinical professor of pediatrics at Mohammed bin Rashid University in UAE. He is a fellow of both the Royal College of Physicians and the Royal College of Pediatric and Child Health. Professor Thalang built the pediatric endocrine service at Al Jalila Children's Hospitals into a major center for pediatric endocrinology, including founding the UAE's first pediatric endocrinologist fellowship. He has authored or edited 4 books and has over 120 publications. Professor Thalang, I look forward to your lecture about the challenges of managing homozygous familial hypercholesterolemia and pediatrics.
Thank you very much. My pleasure to be with you all this evening. I don't know if we were quite the first. I think we were the first Saudi board pediatric endocrine fellowship, so I apologize if that information is incorrect. Anyway, the homozygous familial hypercholesterolemia is a terribly difficult condition. So let me start straight away with a patient, Khalid. Can I have the next slide, please, Michelle? So he was playing a football match when he collapsed with sudden onset crushing central chest pain with loss of consciousness, which was immediately recognized by those around as potentially a cardiac emergency. An ambulance was summoned, and fortunately he was able to get to hospital within a short time. He, on arrival in the emergency department, was tachycardic. He was hypotensive and clearly unwell, and the immediate suspicion was a myocardial event. Next slide, please. His ECG showed widespread ST segment depression in leads 2, 3, AVF, and V4 to V6. So this is characteristic of NSTEMI. I won't say more than that because there are more knowledgeable people about NSTEMI than me, but it's something we don't tend to see in pediatrics, and that's one of the challenges of this. People don't think about the potential for hypercholesterolemia as a cause of ischemic heart disease in children or adolescents. Troponin I was very high, so this is a characteristic non-ST elevation myocardial infarction affecting the inferior and lateral left ventricle. And his echocardiogram, additionally, apart from having low ejection fraction, showed that he had aortic valve thickening and calcification at the aortic root. So this is not a good situation. Physical exam showed widespread extensor tendon xanthomas on his Achilles, on his fingers, and in particular interdigital xanthomas. So the xanthomas between the finger webs or on the finger webs are characteristic of homozygous FH. They're sort of more or less considered pathognomonic. And the problem with very high cholesterol, even at a young age, is that it causes accelerated atherosclerosis. And actually, potentially the process is even starting in utero. So in fact, in infants who are known to have homozygous FH, you can demonstrate very, very early evidence of atherosclerosis. Next slide, please. I should just point out the reference at the bottom of the slide there points to the death of a 4-year-old from homozygous FH. You can even see ischemic death from ischemic heart disease at a very young age. So I mentioned the pathognomonic changes on the extensor tendons, and there in the panel marked number 3, you can see the interdigital xanthomas, which really are absolutely typical. Obviously, you can see premature corneal arcus with familial hypercholesterolemia, but in this case, it was complete arcus in a complete circle around the cornea. So that is unusual, and again, is a strong pointer to homozygous FH. He's got, as you saw, supravalvular aortic stenosis developing. And what was a bit sad was that despite the presence of these physical signs, which could have led to a diagnosis, they had been dismissed as fatty lumps by his physician. And I think, if you're seeing fat somewhere you don't expect it to be, at the very least, check a lipid profile. Next slide, please. So this was his lipid profile, and you can see it looks pretty horrible. So total cholesterol of 680 with an LDL of 580. So an enormous atherogenic load from high LDL-C. But in addition, that's compounded by having a low HDL cholesterol and even somewhat elevated triglycerides. So he's even got some additional atherogenic burden from circulating VLDL. And then, as it were, to put the boot in, he has a high lipoprotein little a. So about 1 in 4, 1 in 5 of the population has high lipoprotein little a, and it's sort of an insidious silent risk factor, which often co-segregates with FH, hetero or homo, but it doesn't have to. It can be there on its own. And the problem is it's highly atherogenic, particularly for the coronary arteries, and predisposes to stroke, heart attack, aortic stenosis. It's pro-inflammatory, causes venous thromboembolism. So it's a really, really problematic particle. Now, I mentioned that he's got an agglomeration of risk factors here, the high LDL-C, the high triglycerides, the high lipoprotein little a, and all of that can be measured by apolipoprotein B. So that is all of the atherogenic particles in a single number. And I think actually more or less, this is just my opinion, you might disagree with me, but I think this is what we should be measuring. So yes, do the lipid panel as a diagnostic tool, but the ApoB is actually should be the target of therapy, and it should be what we're aiming at reducing. And of course, because he's got this additional risk factor of lipoprotein little a, that's really giving him a big additional risk. So you can understand why this poor lad is collapsing at the age of 15 on the football field. Next slide, please. His parents are first cousins, which is relatively common in UAE. His parents were known to have very high cholesterol, not formally labeled as heterozygous FH, but clearly that's what they have, because with these kind of LDLs, that's the cause of such high levels. So not at the homozygous level, but at the heterozygous level. So LDL over 190 is the flag that should tell you you're potentially dealing with heterozygous FH. He had paternal uncle who died of myocardial infarction at the age of 42. His paternal grandfather died at the age of 45. So in addition to that known hypercholesterolemia, he's got an adverse cardiovascular history. Of his siblings, he has 3 siblings. His older sibling, Fatima, has been tested and found to most likely have heterozygous FH, and we should be treating her because the threshold or the age at which we would want to treat heterozygous FH to preempt the development of premature heart disease is 8 to 10 years of age, and homozygous is different. You treat that straight away. So his younger brother Omar and younger sister Layla haven't yet been tested, and it's actually urgent that they're tested because there's a 1 in 4 risk for each of them that they also have homozygous FH, and we certainly don't want the first manifestation of HoFH to be sudden death. The next slide, please. He had a homozygous pathogenic variant in the LDL receptor gene. So LDL circulates, obviously, and VLDL and remnant particles, and it's that those particles are taken up by the LDL receptor, which sits on the liver. But if your LDL receptor is broken, then nothing happens. The LDL circulates endlessly, and in this instance, this mutation is known to be associated with less than 2% activity of the LDL receptor. So essentially, the LDL receptor is non-functional. And you can see the left-hand sorry, the right-hand panel there, just showing the LDL is accumulating in the bloodstream, not going anywhere. There are some options that we have for treatment, which are shown at the bottom there, which I'll come on to. Now, the vast majority, sadly, of patients with HoFH are not recognized. It is a rare condition, only perhaps 1 in 160 to 1 in 300,000, but actually in our region, in the Gulf, heterozygous FH is about 1 in 112, so a lot more common. We don't have reliable data on homozygous FH, but it's likely to be significantly higher than most parts of the world. And unfortunately, the consequence is you have lifelong extreme LDL elevation, premature atherosclerosis, and premature death. And in fact, the mean age of cardiac event, at least in males, is about 12 and a half, and it's not uncommon to have passed away, sadly, by maybe 20, 21 years of age. So this is a deadly disease, and it must be recognized early if we're to give those affected a better chance in the future. Next slide, please. So what do you do? It's a tricky situation. The current guidelines say that we should start with a statin and ezetimibe, and so we do that, but with really little expectation of success, as I'll explain in a moment. But it is recommended as the first line. So statins and ezetimibe, so that's a high intensity, so a high dose statin with ezetimibe does or may have some effect. You know, it can get the LDL down by 10 to 25% in this situation. You remember, you don't have the LDL receptors to do the job. And after 8 weeks, you see that his LDL had only fallen to 490. So if we were seeing him with an LDL of 490, we'd be saying you've got homozygous FH. So it's still at a very, very high risk level. And his ApoB is also still very high. So fundamentally, the problem is that all of the common drugs used to treat hypercholesterolemia act via the LDL receptor, whether that's statins, ezetimibe, or PCSK9 inhibitors. They all work through the LDL receptor. Bempedoic acid, fibrates, they're all going via the same pathway, which is broken. Next slide, please. So the next step on the pathway is to add a PCSK9 inhibitor. So in UAE, alirocumab is approved from age 8 and evolocumab from age 10. So because of his age and perhaps possibly greater efficacy of evolocumab, he was started on that. So this is a monoclonal antibody that helps to normally to prevent the recycling of the LDL receptor from the hepatocyte. So the LDL receptor stays expressed for longer, is able to clear more LDL. But in this case, the LDL receptor isn't working, so it doesn't really do much. And you can see that even with this, so he's now on 3 different drugs, and his LDL has fallen to 410, which, it's a worthwhile reduction, but it's still only 29% from baseline. And his ApoB is still over 250. And LPA little a has not changed. Unfortunately, when you have homozygous FH, whereas normally it does respond somewhat to PCSK9 inhibitors, it doesn't respond at all, really. So in clinical trials, the Tesla study showed that evolocumab did reduce LDL cholesterol by around 23% in HoFH. But as you would expect, that's those who've got a bit more residual enzyme activity. If there's no activity, you're really not going to see very much response, as in this case. Next slide, please. So what are our options? We've got to the end of the road as far as conventional therapy is concerned. So we have we have some options. So we have evinacumab, which I'll talk to you about in a moment. We have lomitapide, and we also have lipid apheresis. And in the absence of access to these very expensive therapies, evinacumab and lomitapide, lipid apheresis is really the only option, but it's also not easy. It's very costly, it's burdensome treatment, and it's not available everywhere. So it's not, for example, available in UAE. So we do need to step up. So what can we do? Next slide, please. So evinacumab inhibits a protein called angiopoietin-like 3, and that has an indirect effect. So it's an inhibitor of an inhibitor, in effect, and it enhances the action of lipoprotein lipase and endothelial lipase, and allows LDL clearance via LDL receptor independent pathways. So it does have a very good impact on LDL. And you can see from the ELLIPSE study, there was around a 47-48% reduction in LDL cholesterol with evinacumab. So it's an indirect way, essentially opening doors that are normally closed for the clearance of LDL. It's an IV infusion given every 4 weeks, so it's not easy, but it's probably easier than lipid apheresis. It is approved by the FDA from age 1 year and by EMA from 6 months of age. So, we can start very early with these treatments, because you have to start early if you can to avoid ending up with a heart attack at a young age. The approval for down to 6 months and 1 year came from the compassionate use study of evinacumab in children around the world, and it was the really convincing safety data from that study which led to these approvals. So for Khaled, we would expect that he should get around a halving of his LDL to perhaps 215 if he is able to get that 47% reduction, and that's clearly worth having. Next slide, please. Now, lomitapide is a drug that's been around a bit longer, actually. It's a very effective drug. It also causes around a 50% reduction in LDL, and it does this by giving you essentially A-beta lipoproteinemia. It stops the assembly of chylomicrons assembly via inhibition of microsomal triglyceride transfer protein in both the intestine for chylomicrons and the liver for VLDL. And by essentially you starve the body of all the lipoproteins, but you also simultaneously impair fat absorption and digestion. So they do need to have a very strict low-fat diet, and it's recommended no more than 20% of calories as fat, which may sound a lot, but actually it's a very limited quantity for most people, and really quite a difficult diet to tolerate. You need to supplement with fat-soluble vitamins, and because there's impairment to fat absorption, you get GI side effects very commonly. But it is effective, and we do have long-term data, over 10 years of efficacy and safety data. So it's certainly a worthwhile option, and it also has the advantage of being an oral therapy, in contrast to evinacumab, and clearly much easier, potentially anyway, than lipid apheresis. Next slide, please. So lipid apheresis is actually the treatment that's been around for the longest, and it does work very, very well, but there are some problems with it. First of all, so essentially you're hooked up to a dialysis circuit, but it's got different filters in the machine to clear out the lipids or the LDL cholesterol. It has to be done every 1 to 2 weeks, so it's not as bad as dialysis, I guess. Each session lasts for up to 4 hours, and you're going to determine how often you need to do it according to how much the LDL falls with each episode or each treatment session. And you can get a significant reduction in LDL, but of course it only is a brief reduction. It starts to rise immediately after the dialysis session has finished. So you get this sort of sawtooth pattern. So in aggregate, it amounts to around a 30 to 40% reduction in LDL cholesterol. And actually, it doesn't prevent the progression of atherosclerosis. So even though it's reducing the cholesterol significantly and it is worthwhile, it's not able to prevent atherosclerosis from continuing to progress. So it's not probably for most people a great option by itself. But sadly, in our case, in UAE, we don't have access to lipid apheresis, although I'm aware there are 2 centers in Saudi and 1 center in Oman, and I think a center in Qatar as well that we can access if people are willing to travel. And of course, it's quite burdensome to the family to be considering traveling every 1 to 2 weeks for this therapy. Next slide, please. So there was a very interesting paper published in JACC last year, which was a case report of a Japanese boy with very severe homozygous FH, who had received all the customary baseline therapies with statin, ezetimibe, and lipid apheresis. And then he actually went on to lomitapide and evinacumab, and that combination was effective in reducing his LDL and reduced the frequency of the apheresis sessions. So he wasn't free of apheresis, but he did at least manage to not need it so much or so often. And carotid plaques visibly regressed on treatment. And really, this is the first time that we've seen that with any combination of treatments for homozygous FH. And it may well be, and I throw this out there as an idea, that actually for these patients, it's combination therapy that we need, and if possible, to reduce the frequency of lipid apheresis, which I think is very burdensome and challenging to maintain. Next slide, please. So obviously, while we're thinking about Khalid, it's also important to think about his relatives. So we must test both his immediate relatives, but also we should make an effort to track down other family members as well who may be at risk, because often in the families we have in UAE, there's often multiple siblings, multiple generations as well. So there's lots of potential patients who perhaps need treatment and at least need identification. Heterozygous FH, relatively straightforward to treat by comparison with homozygous, but there will potentially be some homozygous cases amongst them. So we need to do a lipid panel for his brothers and sisters. We need to do genetic testing to identify the specific LDL receptor variant in Khalid, which we did, so we've got that, and then the cascade testing, and plus for heterozygous cases, starting early with statins. Now, 8 to 10 is, what was found to be effective in the Dutch studies going back now 30 years. I would veer towards perhaps starting a little earlier if there's a very adverse cardiovascular history, because I think that combination of high LDL and adverse family history is telling you something important. That's someone who's more predisposed. And obviously in this situation, where you have high Lp(a) as well, there are some additional benefits from hitting harder earlier. Next slide, please. So we're nearing the end, you'll be relieved to know. So what I would say about homozygous FH is that it's a medical emergency. It's not a trivial condition, and it leads to premature atherosclerotic cardiovascular disease and death. Physical signs are typically present and often have not been noticed or not heeded, even by medical professionals. Perhaps I would say particularly pediatricians who are not used to seeing, ischemic heart disease. But our standard therapies, which we use for lipid disorders, simply are not effective, or at least not effective enough. And so we therefore need to think about switching quickly. You've got to maintain the rate of progress. So we're not just leaving this child, languishing on ineffective therapy. We need to progress to the LDL receptor independent therapies, so evinacumab and or lomitapide. And as I've shown you, combination therapy does appear to be good as a strategy and may reduce the frequency of lipid apheresis. ApoB is actually what I think we should be measuring, although I've talked about LDL cholesterol the whole time, but actually ApoB is a more comprehensive marker of the total cardiovascular risk. And don't forget about the relatives. Cascade screening is a must. So you've diagnosed this patient. What about the other patients you haven't seen? And then we have our regional challenge here in UAE that we don't have lipid apheresis available. Next slide, please. And I think this will be my last slide. Yes, so here we have Khalid. So he survived his myocardial infarction, but with severely reduced ejection fraction and a tough road ahead. He needs aggressive multimodal therapy to keep his LDL down so that he may be able to avoid a second event. Even the LDL target we have for him as a pediatric case, less than 115 milligrams per deciliter or 3 millimoles, is really not sufficient for secondary prevention. He's already had an event. So really, we need to go as low as we possibly can in him, which is unfortunately easy to say and very hard to do. And his prognosis is really guarded. So really, it's a stark reminder of why we have to diagnose this condition at as early an age as we can, because the consequences of not recognizing it are devastating and maybe fatal or, life ruining, really. So thank you for your attention. I will now pass you back to Dr. Asma, references there.
I think it's Dr. Tariq to introduce the next speaker, please.
Dr. Tariq, I apologize.
Welcome all. Thank you very much for having such wonderful and highly educational, and I assume it's going to be a highly interactive session. Thank you, Nando, for kicking start the meeting. Now it gives me great pleasure actually to welcome our next speaker, Dr. Nadi Al-Khulaif. Dr. Nadi is consultant in Department of Cardiology and Echocardiography at King Faisal Specialist Hospital and Research Center in Riyadh. He's also an associate professor in King Faisal University Medical School. Nadi has a special interest in familial hypercholesterolemia. This is where actually most of his research is focusing, in addition to other areas of excellence. Nadi has recently actually published one of the largest series on familial hypercholesterolemia in the Gulf. With no further ado, Nadi, the center stage is yours.
Well, thank you for this great introduction. It's really my pleasure. I really like to appreciate and thank the International Atherosclerosis Society. Actually, this is going to be probably the first, with of course the support of GenFarm, but it's also my pleasure to have this as the first collaboration with the Saudi Atherosclerosis Worker Group that is just started with me and Dr. Fahd Al-Nouri and others. I'm really happy to give this talk, and which is important, and I'm really happy to be a part of this expert panel. So today I'm going to talk about breaking the cycle of late diagnosis in homozygous familial hypercholesterolemia. These are my disclosures. Next slide. So the prevalence, as you can see, is high in the region. In Tunisia, homozygous 125,000. In Lebanon, it's about 100,000. And in Qatar is about 125 is heterozygous. And the Gulf registry, which is the next, it's about 112. These are heterozygous. Fortunately, homozygous, we have less information and less data on these patients. Hence, we would like to work to have a really national and international Gulf registry to detect the prevalence. Next. So homozygous familial hypercholesterolemia starts very early, as early as in utero. So you can see the fat cells here in a fetus who's 20 weeks old in an autopsy. Next. So it's really the cascade of atherosclerosis is really driven by LDL, and high LDL progresses over a long period of time. Next. And this could be really shown in imaging, whether it's CT scan or pathology. Now, if you look at this slide, we are looking at patients. We initially looked at patients in our clinic just to have an idea of what's the burden of disease. The LDL, when they first present, is about 14 millimolar per liter. And if you focus on here in this clinic, by the time they reach an adult cardiology and lipidology, we already see that 30% already had coronary artery bypass surgery and an aortic valve replacement. So 30% of those who reach our clinic have coronary artery bypass surgery and aortic valve surgery. Next. So to really see the disease, we decided to look at all the patients who either came in to the hospital, since it's a referral center. So we took everybody who ever had an LDL more than 8 and gathered them. We ruled out common causes for hypercholesterolemia like chronic kidney disease, hypothyroidism, and really those who weren't lost to follow-up, and we really could determine that, and we ended up with 127 patients, so with truly homozygous familial hypercholesterolemia. Mean LDL is 15. The mean LP(a), so the mean LP(a), when we look at those who had LPA more than 75, so some have normal, but those who have more than 75, the mean was 180. Xanthomas with about 74%, and arcus cornealis about 11%. Treatments, statin, zitimib about 73%. 30% have been at least tried for a period of time, PCSK9 inhibitors, a lot of whom discontinued because it didn't work. And 22% actually had liver transplant, which is somewhat higher than most series because the center is a liver transplant center, so we had proportionately higher numbers of liver transplantation, particularly in adults and adolescents, and 22% of the population had plasmapheresis. Next. Slide before this, sorry, Michelle. The last, okay, next, that's fine. Okay, so the signs, so 11% have arcus cranialis, 74% have xanthomas. Next. So here, when we look at the survival, the median overall survival was about 37 years old. But if you look at the Kaplan-Meier curve, you see that there are patients who start having mortality as early as 3 and 5 years old. So although there is a big drop later in teenage and then in the 30s, this disease really start having mortality at a really young age. Next. So in our cohort, we have 3 patients who had sudden cardiac arrest before the age of 9 years old. So 1 patient at the age of 5, 6, and 8. And, you know, this is a really devastating to have a young child less than 9 years of age having a myocardial infarction. Next. And if we look at this slide, so here we're looking at cardiovascular event-free survival. So event-free meaning not requiring to have a surgical intervention. Here, by the median age is 28, and you can see the Kaplan-Meier really steep. So a lot of patients requires either aortic valve replacement or coronary artery bypass surgery or percutaneous interventions really early in their life. By the time they're in their 20s, more than half of the patients already have had a major surgical intervention. Next. So treatment. So the treatment here is complicated, and there, Dr. Nando went through receptor-dependent and independent pathways. Next. But you can see here, adults and pediatrics are not treated the same. So these are the patterns of treatments in our cohort. And we can notice in the blue, adults. So most adults are treated with statin, ezetimibe, and about 40% had evolocumab, relative to pediatrics, as well as plasmapheresis. But in pediatrics, using these medications is far less. But we do see them, most of the patients who had liver transplantation had those at the early ages in adolescence. So the pattern of treatment is different between adults and pediatrics. Next. And liver transplantation is really effective in lowering LDL immediately after transplantation. So in a study done by Dr. Afaf Al-Saghir and Dr. Ashwal in our institution, we noticed that immediately post-transplant, LDL on average goes down from 20 to 3 millimoles of mercury. Now, there is caveats. So let's look at the next slide. That after a period of time, you can see, so immediately a post-transplant LDL goes down quickly, but over time, we notice a pattern where LDL does start to increase over time. And therefore, we have to be really vigilant, even with those who have transplantation, since their LDL of 5 is still dangerous and still can predispose to cardiovascular disease. Next. So do PCSK9 inhibitors work? So that in the Tussing trial, we see there was a reduction in LDL cholesterol. Next. And this is the study that Dr. Nando was alluding to, the TISLA B, which showed a 31% reduction. However, in this study, we had all comers, and a lot of these patients had residual LDL function. So if we go to the next slide. When we look at those with LDL receptor function normally, you can see a reduction of about 23%. Next. But when we look at those who had one patient who had a LDL receptor that was null, there was no reduction. And again, when we look at real-world data using PCSK9 and homozygous familial hypercholesterolemia enriched by Saudi patients and those in the region, the reduction in LDL is really, in response to PCSK9, is really blunted. Next. So lumitibide real-world data shows really good reductions, and some patients actually are able to reach targets of 70 and 100. Next. In our own populations, we also have some examples of patients that really had really good response, although once they get off the medication, they rebound to numbers that sometimes are even higher than when they started with. Next. And these are two other patients who were started initially, and these are in our cohort, that also show similar reductions in LDL with lumitibide after treating for 3 and 5 months. Next. And in the big study in which lumitibide was tried in patients who had who were 5 years to 70 years of age, and broken by age group, which was really enriched by patients from the region, and in the Lancet, published in Lancet Endocrinology, we can see significant reduction in LDL cholesterol throughout the board and in different age groups. Next. Evinacumab has also been shown to be really effective in patients and younger adults who have homozygous familial hypercholesterolemia. Next. And we can see a significant reduction compared to placebo. Next. And what is interesting is that this reduction in LDL is independent from whether the receptor was null or none and null and so forth. Next. The new frontier, of which going to be a lecture dedicated for this, is going to be talking about using these technologies as CRISPR to actually edit the genes and have a one-shot and done kind of objective. First was tried on the mammals for PCSK9 inhibitors. Next. And then later on, this was tried in adults. Next. Patients. And it's important to recognize that sometimes there could be some challenges. Next. Where, so even though you can have good reductions, in these patients, there's sometimes there could be potential off target. So in this first 101 dose escalation phase 1, we had 2 cardiovascular events occur in these patients. Next. Now, more relevant to homozygous familial hypercholesterolemia is gene editing is attempted in angiopoietin-like peptide 3 using the same technology of small interfering RNA. Next. Where we try to use the GalNAc conjugation to deliver the cargo to the nucleus, and then with the CRISPR technology try to edit out or silence angiopoietin-like peptide 3. Next. And this has resulted in significant reductions in LDL, albeit in a very limited capacity. This is still really early observations. Next. And in phase 1 clinical trial that shows that angiopoietin 3 could really be inhibited in about a number of patients in a paper done by Levine last year. And this is really promising. Next. So what must trigger same-week assessment? So if you have an LDL more than 10, xanthomas, parents with heterozygous aortic stenosis in the youth, you should immediately start thinking that this child could be a homozygous familial hypercholesterolemia. Next. So the idea is to move from detection upstream. So EAS, CCS, and ESC all recommend really being aggressive. They put them patients in high risk. And the issue is not moving, is really moving from can we diagnose to which national mechanism is responsible for finding children before the events. Next. So we need hospital clinics, so hard alerts, LDL that's really high, xanthomas, premature cardiovascular disease. We need same week lipid referral, shared pediatric adult board. Regionally, we identify founder variants, have apheresis map capacity, family cascade coordinating, and telelipid case conferences. And nationally, we need to have a registry, and this is a call out for us all to join in really developing a national and international registry, protocols for normal therapies, newborn pilot integration, and public metrics dashboard to monitor our progress. Next. So we need to recognize, have them to a specialist as fast as possible. Combination, lower lipid therapy, imaging. So we have to make sure that we image. So echo, CTs, make sure we're looking at the aorta, look sure LV function, look at the vessels, and escalate, including liver transplantation or plasmapheresis as needed. Next. So detection. Red flags, LDL more than 10, family, treatment, we have to get to a specialist as soon as possible, try to control the disease longitudinally, and finally, we need to measure hard outcomes and make sure that we're doing a job we should all be aspiring to do. Next. So, a lot of times we have answers, but the questions are more important. Is it too rare? Is the genetic testing expensive? Is it justifying advanced therapies that are costly? And maybe families don't accept cascade testing. All these questions are challenges that we all have to know and face and be able to answer with evidence and our real-world experience. Next. So a call to actions. There are 3 decisions for expert consensus. Adopt the National Homozygous Familial Hypercholesterolemia Trigger Protocol, fund cascade coordinating and founder variant testing, and attach detection to treatment access. In Saudi will, so take home messages. Homozygous is a pediatric disease with adult consequences. The disease starts in pediatrics. Sometimes it even manifests as pediatric, but definitely by the time adults, we really had advanced disease. Late diagnosis is a system failure, not a knowledge gap. Anybody can see an LDL more than 10, but it's what you do once you identify this, and that's a system issue. Early detection must trigger immediate action, and not think or try to do attempts, but rather have the patients exposed and access to really highly effective treatments. Saudi Arabia is uniquely positioned to lead. High consanguinity, founder variants, and strong tertiary center creates high-yield cascade screening, and precision medicine is the future. And lastly, last point I want to take home messages from this next slide, on my final slide. The final call to action, we should move from incidental detection to protocol-driven identification, from individual patient care to family-based intervention, and from delayed referral to immediate treatment pathway. Thank you.
Thank you very much, Nadi, for such enlightening talk about homozygous familial hypercholesterolemia. I'm sure we'll have so many sort of issues to ask you about regarding your research and the registry. Now we move on with such actually fabulous program on homozygous familial hypercholesterolemia. It takes me special pleasure and honor to welcome our next speaker, Dr. Samir Al-Isa, who is head of the Department of Endocrinology, Diabetes and Metabolism at Jabir Al-Ahmed Hospital, and a staff physician at the Dasman Diabetes Center in Kuwait. Dr. Al-Isa is American Board Certified in Internal Medicine. He's also a fellow of the American College of Endocrinology, and currently, actually, he is a board member as well as secretary of the Gulf Association of Endocrinology and Metabolism. Dr. Samir is going to give us the next talk about the gold standard in management of homozygous familial hypercholesterolemia. Dr. Al-Isa, the floor is yours.
Good evening, everybody. Thank you, Dr. Tariq, for the kind introduction. Thank you for the sponsors and arrangement from the International Atherosclerosis Society in collaboration also with the GATE Association to bring you this webinar. So very delighted to present this presentation. This is, we're trying to talk about specifically more of a gold standard treatment management as a core for the management of patients with hyperlipidemia, specifically also including heterozygous and homozygous. Next slide, please. So you've heard about several ways of managing patients with familial hyperlipidemia, including pediatrics, and also moving on into adulthood. But I want to still concentrate more on the statins and how they are cornerstone in the management still in patients with familial hyperlipidemia. So the efficacy and safety of statin in adult with a primary and even secondary prevention for atherosclerotic cardiovascular disease is well established since probably more than 30, probably I would say 40 to 50 years now, describing the effect. And statin monotherapy, definitely in familial hyperlipidemia, wouldn't be sufficient to achieve the guideline recommended in LDL levels, even in patients with heterozygous. Next slide, please. And this is what we are mentioning here in terms of patients using statin therapies and the free survival time from coronary artery disease. This is a cumulative CAD free survival among patients with familial hyperlipidemia. These are patients who have been followed for about 8.5 years. Describing the Kaplan-Meier curves the cumulative events free survival rates, and you can see patients on statin therapy in blue and patients without statin therapy. There is an increased risk of about 76% risk of developing coronary artery disease if these patients are not on statin therapy. Next slide. And this is also as well the consequences in patients who are on statin therapy. This is an overall effect of what we can achieve in reducing coronary artery disease and all-cause mortality. This is about more than 1,500 individuals with heterozygous familial hyperlipidemia. They're treated with statins. The most common was simvastatin 40 milligrams and also as well atorvastatin 40 milligrams. So they have a difference in efficacies or in intensities of LDL reductions. And you can see as an overall effect, there is about 0.56 in hazard ratio reduction in the all-cause mortality and coronary artery disease. And you can see as well, the higher the baseline LDL level, the further reduction in these outcomes you can achieve. That means there's a disease burden is much larger, and with reduction of LDL, you can achieve much lower effects in reducing mortality and as well coronary artery disease. Next slide. So in heterozygous familial hyperlipidemia, patients on long-term statin treatment have been shown to exhibit similar degrees of carotid artery plaques and intermediate thickenings to a reduction in subjects with the general, comparing to subjects in general population. So the endpoint, the vascular endpoints would be similar here. And when you do aggressive LDL reduction by high-intensity statins, for example, here in this study, use 80 milligrams of atorvastatin for over 2 years. This was accompanied by a regression of the carotid intermediate thickening in patients with familial hyperlipidemia. It was not observed as much with conventional therapy when using much lower efficacy with a simvastatin 40 milligrams. So even though statin therapy do work, but also selecting on the type of a statin and how much reduction of LDL definitely can help to reduce further out endpoints. Next slide. One of the trials that looked into observational effects of statin therapies and on long-term effects, this is the WOSCOPS trial. So this is done on a general population. A lot of them probably had as well familial hyperlipidemia. In one analysis that was published about 10 years ago, looking for individuals with an LDL level of equal or more than 4.9. And these patients were only on pravastatin, which is one of the lowest efficacy statin therapies, about 40 milligrams. And these patients, most likely, so a lot of them would have familial hyperlipidemia given their baseline LDL level. So during the initial trial phase, these patients had a significant risk reduction of coronary artery disease by about almost 27% and major adverse cardiovascular events by a reduction of about 25% in the initial trial. With follow-up for up to 20 years on statin therapy, with this kind of a statin therapy, there was still reduction of cardiovascular endpoints. CHD death was reduced by 28%, cardiovascular death was reduced by about 25%, and all-cause mortality was reduced by 18%. Next slide. And this is basically as well looking for these outcomes. This is a smaller individuals. This is a homozygous patients with familial hyperlipidemia in South Africa, about 150 patients, looking for effects of statin therapy on long-term treatment plan and follow-up. So these are patients predominantly on statin therapy to lower their LDLs, rosuvastatin 40 milligrams or atorvastatin 80 milligrams. And we know both of these are high efficacy statin treatments. They can reduce LDL of significant levels. And these patients, even though they're homozygous, they were still able to reduce the effects on endpoints of death, about 66% reduction you see in panel A or in diagram A. And in B, there is also reduction of 51% reduction in MACE outcomes. So even though these patients have only mean reduction of LDL of about 26%, and you can see in the lower box, there still patients had a significant reduction in the death and MACE outcomes as well, showing the effect of statin treatments in achieving that outcome. Next slide. And this gives us the concept of LDL burden. This was also alluded to in the previous presentations. Patients, when they are much younger, starting with a very high levels of LDL, if you can see in the purple line on the left side, these are the patients with homozygous familial hyperlipidemia. So these patients accumulate LDL significantly in the vasculature bed, promoting earlier and earlier onset of developing coronary artery disease. And while patients, if they are more heterogeneous or even general population, they tend to take much longer to develop these events just because of the LDL accumulation in the vasculature bed becomes delayed because of the levels that they start with in LDL is actually lower compared to the homozygous. And that gives us the idea of when appropriately we need to start treatment, specifically here when we're talking about statin treatments. If you can see the red line, this is patients, heterozygous patients with familial hyperlipidemia. When you decide to starting a low statin dose about age of 9 years old, you can actually reduce the prospect of developing cardiovascular disease from an age of 35 years to an age of 53 years. If you start a statin treatment when the patient is about 18 years old, then you can delay the effects of coronary artery disease from age of 35 to the age of 48. So the sooner you start, the more extension for development of cardiovascular disease you can achieve by earlier therapy. This burden and this development of cardiovascular disease much becomes sooner if these patients, unfortunately, would have as well other secondary causes to develop atherosclerotic disease, specifically smoking, hypertension, diabetes, elevated triglyceride and low HDL, more towards metabolic syndrome, and also a genetically elevated lipoprotein little a. Next slide. So initiation with the maximal potent statin dose in patients with familial hyperlipidemia is advised. Only very few patients, maybe 1 out of 20, can achieve some recommended LDL targets within that genetic pool. Most of these individuals will need at least a decrease of LDL by about 50%, which sometimes a lot of times these statin therapy might not be able to do it by itself. Many receive statin doses insufficient, unfortunately, to attain the LDL targets from the beginning. And then we need to be more selective in how to do the doses from the beginning by mainly selecting the appropriate dose rather than starting small dose and then titrating up. And many physicians do not really, and that's what we're talking about, do not really up-titrate the statin doses despite this optimal treatment. And that tells us about when we initiate treatment, we initiate it at the right dose, the right combination at the right time as well. And the clinical assessment of efficacy and the safety as well, you can do that as advisable about 4 to 6 weeks after initiating treatment. And if you do any significant changes in the treatment, you can also monitor that after 4 to 6 weeks. Next slide. This is what happens if patients would not really using appropriate treatments, and what happens if patients were not really treated with statin appropriate. But this is the Copenhagen General Population Study. The prevalence of coronary heart disease, this is among patients with definite and probable FH patients, about a third of these individuals. If you look at the bottom, these are definite or probable FH patients. If they are on statin versus off statins, you can see the odds ratio of developing these the coronary heart disease risks. And these patients, unfortunately, a lot of them will not be on a statin treatment. So we're still under treating a lot of individuals. In this group of cohort, they've seen about 48% of subjects with familial hyperlipidemia receiving statins only. That leaves half of individuals subjected to increased risk of developing cardiovascular disease and not on appropriate treatment. Next slide. And this is what tells us that from the insurance companies is that if you start treatments in patients on familial hyperlipidemia, you can definitely reduce the excess mortality rating in these individuals. So this is the life insurance companies looked at patients when before and after they starting treatments, they can see the lifespan of these individuals actually gets larger. Next slide. And this is what's recommended goals for patients with familial hyperlipidemia. This is from the expert clinical consensus, which published very recently in just a month ago in April from the National Lipid Association, describing the recommended LDL goals for patients, whether they are secondary prevention, recurrent events, extreme risks, primary prevention, adults, and pediatric age. You can see these recommended LDL levels with levels of less than 55, 40, 30 milligrams of LDL. That corresponds to about a 1.4, 0.8, and less than that in patients with millimole LDL reductions. And also as a primary and secondary prevention, with also additional goals of non-HDL and ApoB goals. Next slide. This is from the European Society of Cardiology, describing general population reductions of LDL and its specific targets. Also, they labeled patients with familial hyperlipidemia as well as significant risk individuals that they need to be reaching a significant goal of LDL. You can see at the high risk group, there are the patients with familial hyperlipidemia without other major risk factors. The LDL needs to be less than 1.8. Patients with familial hyperlipidemia in the very high risk, these are patients with FH, with atherosclerotic cardiovascular disease or other major risk factors. Their LDL needs to be less than 1.4. And patients in the extreme risk here, which is not really specific to patients with FH, there are general population with any genetic backgrounds who do have atherosclerotic cardiovascular disease and experiences recurrent vascular events. These patients are extreme risk and their LDL needs to be less than 1. Given that these patients as well, they have to have achieved more than 50% reduction from baseline, reaching as well these goals. And they are close enough to the NLA recommendation, which we showed in the previous slide. Next slide. And also here, this is also relatively new from American Cardiology, College of Cardiology, American Heart Association, also published in last March, describing lipid management in patients with primary or secondary prevention. I can take you to the group where they're talking about severe hypercholesterolemia groups. That would be the second row. And they're here describing patients with FH that they have to have with atherosclerotic cardiovascular risk. Their LDL targets needs to be less than 1.8, when non-HDL needs to be less than 2.6 millimoles. And if they are actually severe hyperlipidemia with or heterozygous with a clinical atherosclerotic cardiovascular disease, their LDL levels needs to be less than 1.4 millimoles, and non-HDL needs to be less than 2.2 millimoles. Very similar as well to the previous to the European guidelines. This is what we're talking about statin intensity, high statin intensity that's able to lower LDL by equal or more than 50%. Usually, these are the atorvastatin between the doses of 40 to 80 and rosuvastatin between the doses of 20 to 40. A majority of other statins are moderate intensity. They can reduce LDL by 30 to 40 to 50%. And low intensity statins probably not really a good pick for patients with FH, since they are minimal in reducing LDL. Even in moderate intensity statin, these patients probably would not definitely reach a goal with that. Even high intensity statin, they need an add-up combination treatment to reach that goal. Next slide. So this is what we mean about combination treatments. I'm trying to present here the high-intensity statin plus ezetimibe, which can achieve patients' reduction of LDL about 65%. Again, some patients might not really able to reach the goals with these levels, but we can control some of the heterozygous as well. But with the homozygous, usually we need further reductions, and PCSK9 inhibitors and responders can achieve further LDL reduction, and if not, then the other unique treatments for LDL, which we'll talk about also in the next presentation. Next slide. So one of the key combination treatments we've been using for a long time is ezetimibe, which we also mentioned in previous presentations. So it inhibits lipid transport in the intestines, so it blocks kind of cholesterol absorption, makes the fats, the liver cells depleted with cholesterol because of blocked reabsorption. And that's kind of increases LDL receptors and then reducing LDL from circulation. But that depends on how much these patients able to reduce LDL, but produce LDL receptors, so they can reduce the LDL from circulation. Generally speaking, if we add ezetimibe on individuals using statins, you can achieve a further reduction of about 20, 25, up to 30% reduction of LDL. And it's very well tolerated, inexpensive, and it's generic. That's why it's a kind of an easy to add up to any statin treatment in patients with FH, whether heterozygous or homozygous. There is one clinical trial showing reduction of cardiovascular events. That's the IMPROVE-IT trial. The reduction amount was little, just less than 10%, but it was statistically significant. And the good thing about it is that it's a safe therapy, and the number needed to treat in that effect as well on these patients were not familial hyperlipidemia. It was 50 patients to treat to reach that outcome. So easy, cheap, effective treatment, and we can add it as a combination with statin from the beginning of treatment of these individuals. Next slide. In heterozygous individuals, ezetimibe has been tested. There was one study published many years ago, about 621 patients, heterozygous with 60% of them were heterozygous with familial hyperlipidemia. Those patients receiving atorvastatin 10 milligram daily, their LDL had to be more than 3.36. And these patients were randomized then to receive either double the dose of atorvastatin 20 milligram or add a 10 milligram to the 10 milligram of the atorvastatin that they were receiving. So the mean baseline was about 4.8 millimoles, and the LDL goal was less than 2.6 almost in that study. So the combination with ezetimibe helped patients reach the goals of 22%, while just doubling the dose of atorvastatin only helped patients to reach goal about 7%. So that tells you further reduction of LDL is appropriate. But definitely we're not reaching the appropriate LDL goal based on the current standard guidelines of reaching what is needed in these individuals. Next slide. And here, what happens if we can actually give these therapies, statins, ezetimibe? Are we concerned about adverse events? So the only thing that with statin treatments, if we give high doses usually, and that's what we need to do in patients with FH, sometimes we run into these minor side effects, which are the headaches, the dyspepsias, myositis, and myalgias, elevation transaminases, and the induction of patients moving from pre-diabetes state into the type 2 diabetes state. There's some drug interactions like cyclosporins, fibrates as well, and niacin, and lovastatin can increase the PT at certain instances. So patients on high doses of statins, they need to have a profile check of lipids about 4 to 8 weeks. And then every 6 to 12 months, we need to have a review. LFTs or liver function, we can do that at baseline and 3 months later, and periodically if it's needed. And CK is not really very important as a monitoring unless symptoms happen, but you can test that initially at baseline, and only if there are symptoms you can repeat CK and just try to link it to the patient's symptoms as well. Ezetimibe is very mild therapy, probably non-significant adverse events. If you read these adverse events, this can happen to any individuals, whether on or without the treatment itself. Very mild drug interactions like with cyclosporins and cholestyramines. It can increase any end of the curves of the ezetimibe if you're using cholestyramine with it as well. But other than that, there isn't much of a drug interactions with this kind of treatment. Next slide. So when the statin-induced side effects do actually develop in these individuals, what try to do is that lower the dose of a statin or give it on alternative days, and definitely add more and more and more further lipid-lowering medication, which are the combination treatments. Next slide. So in patients with homozygous FH, the treatment statin reduce LDL modestly in patients with homozygous FH, even in those patients who are receptor negative. So there's a possibility that since statins can lower the synthesis of LDL cholesterol, by inhibiting hepatic cholesterol synthesis, you can actually lower LDL cholesterol. And this could be because of limiting the cholesterol availability for the formation and the secretion of the ApoB-containing lipoproteins in patients who are actually receptor negative homozygous patients. And this and increasing the residual LDL receptor activity in the receptor deficient patients. So this is probably why statins can work in these individuals and lowering the LDL, just because they're blocking the synthesis and blocking the secretion of these lipoproteins containing ApoB. Next slide. And what about genetics responses? So there are actually linked genetic responses to statins based on the ApoB alleles. So FH patients who have ApoB lipoprotein E4 allele are poorer responders to statin treatments than those who are ApoB lipoprotein E2 and 3 carriers. And ApoB E4 allele is actually linked to dementia. So patients who have these alleles are more prone to dementia, and they're actually poor responders to statin treatments. And this is against the issue about that statin treatment can induce dementias. Patients who have loss of function variants in the PCSK9, they are associated with an increased response to statin treatment up to 55%, and that's not really clear how. And data from the genome-wide association studies, they demonstrate that about 5 to 10% their variation LDL response to statin treatments, this is associated interactions with some genetic variants like the ApoB and some other genetic alleles as well. Next slide. What about lipoprotein apheresis? Well, this was discussed. I just want to point it out here for adults population. So it's an important therapeutic intervention. It's needed less than 1 to 2% of patients with heterozygotes, but a much larger group in patients who are actually homozygous. It involves the extracorporeal removal of the ApoB lipoproteins, LDL, VLDL, lipoprotein A, and remnants as well, and removing them from plasma during a procedure that lasts about 34 hours. And during a single apheresis treatment, LDL can be reduced by about 70 to 85%, and LDL can be reduced by about 65 to 75%. But as mentioned before, this is transient. Within a few weeks, unfortunately, these levels actually recover again. So treatment is often repeated every 2 weeks, every 4 weeks in patients who are heterozygous, and maybe even every week or up to every 4 weeks, depending also on patients who are actually homozygous as well. Next slide. So safely used in children in homozygous from the age of 2, especially with specific weight criteria, which has to be more than 15 kilos. The benefit of apheresis beyond the LDL, it can reduce acute reduction in inflammatory markers, especially C-reactive protein. It can improve endothelial function, increase the cardiac microvascular flow reserve, decrease in fibrinogen and procoagulant factors, decrease blood viscosity, and improving the clinical symptoms, especially the angina exercise. Even though we don't have a clear-cut evidence supporting the reduction of atherosclerotic disease, but just the observation trials show there is a reduction, but we definitely lack the randomized control trial to prove that point. Next slide. So this is the indications for lipoprotein apheresis in the US. So here you have 4 groups, Group A and Group A, which is the homozygous individuals with LDL levels more than 500 milligrams without presence of atherosclerotic disease. So this is the level of lipoprotein that apheresis should start with, more than 500 milligrams. If they're Group B, that's heterozygous individuals without atherosclerotic disease, then levels more than 300, you can start treatment. Group C, heterozygotes with levels of more than 70 milligrams. So here, these patients are documented to have coronary artery disease or peripheral vascular disease evidence. So these patients, you start the apheresis at much lower level compared to patients without presence of cardiovascular disease. So heterozygotes individuals with lipoprotein a more than 60 milligram, or LDL more than 70 milligrams, that will be the indications for starting apheresis. Next slide. So take-home points here. So FH treatment should follow recently published FH-specific international and national guidelines and be consistent with evidence-based guidelines for the general population. Statin therapy is mainstay therapy for patients with FH. Added combination treatment is crucial to help patients reach the desired LDL targets. And neuromedication definitely would be very helpful to treat patients with FH for hope for the future. Research is doing as much as possible to help these individuals to integrate the medications with the statin treatment as well. And I think this is my last presentation. Thank you so much for your attention.
Thank you very much indeed, Dr. Laisa. As always, a fantastic presentation. We all enjoyed listening to you, as always. Now, Professor Lambert is going to speak about the newer medications and the gene therapy and precision medicine.
Bonjour. Today, I will discuss precision medicine and personalized treatment for homozygote familial hypercholesterolemia. My name is Gilles Lambert. I'm professor in cell biology and lipidologist at the University of La Réunion Medical School in France. Cholesterol can be lowered in the plasma pharmacologically using different classes of drugs. The first, ezetimibe, reduces the absorption of dietary cholesterol in the gut. The average reduction in LDL cholesterol by this drug is 15%. The very famous statins inhibit HMG-CoA reductase and thereby upregulate the LDL receptor. They sharply decrease LDL cholesterol levels on average by 55%. The new PCSK9 inhibitors work a little bit differently. They block the lysosomal degradation of the LDL receptor, so they preserve the abundance of the LDL receptor, and they can lower LDL cholesterol levels by 60% on average in clinical trials. These two drugs, statins and PCSK9 inhibitors, work through the LDL receptor. Finally, there is a new class of drug, the angiopoietin-like 3 inhibitors, that preserve the function of lipoprotein lipase and endothelial lipase and thereby reduce triglyceride and LDL cholesterol independently of the LDL receptor. This new class of drug doesn't work through the LDL receptor. HoFH is caused in most instances by the presence of mutations on both alleles of the LDL receptor. So to understand which drug fits better this or that patient, it is very important to determine whether there is any residual LDL receptor expression and activity in those patients based on the type of mutation they carry on their LDL receptor. Here we have studied this in vitro using lymphocytes from patients, and we have labeled the LDL receptor using a red antibody. Nuclei are depicted in blue. As you can see, we can upregulate the LDL receptor with mevastatin in the second line, reduce it with the protein PCSK9, and restore it with a PCSK9 inhibitor in the form of aderokumab. When we took cells from homozygote FH patients with some residual LDL receptor activity, of course there was much less LDL receptor expression than in non-FH cells, but this low expression could be upregulated by statin and restored by PCSK9 inhibitor. We used that approach to compare healthy donors, heterozygote FH, homozygote FH defective, and homozygote FH negative patients in terms of LDL receptor expression. We stimulate their cells with increasing doses of statin, and we saw an upregulation of the LDL receptor. This was reduced by PCSK9 and restored by PCSK9 inhibitor. The same pattern was seen in heterozygote FH patient cells, as well as in cells isolated from homozygote FH with defective LDL receptor allele that still carry some LDL receptor expression and function. In contrast, in cells from homozygote negative mutation carriers, there was no effect of statin, no effect of PCSK9, and no effect of the PCSK9 inhibitor that was significant in terms of LDL receptor expression and LDL receptor function. The vast majority of homozygote FH patients carry defective LDL receptor mutation. So, in the next study, we compared patients with homozygote FH that carry identical mutation on the LDL receptor, and we look for the implication in terms of efficacy of PCSK9 inhibition with evolocumab. In that study, we measure the LDL receptor cell surface expression at the surface of cells isolated from homozygote FH patients with different types of mutation on the LDL receptor, and correlated those values with the baseline levels of LDL cholesterol found in the plasma of those patients. There was a negative correlation between the levels of LDL cholesterol and the levels of LDL receptor expression measured at the surface of the cells isolated from those patients. 10 of those patients, represented here by the blue dots, were carriers of the Afrikaner1 mutation. They were all homozygote FH, and they were both carrying on both alleles the Afrikaner1 mutation, which is a defective mutation with some residual LDL receptor activity. Yet, even if those patients carry identical mutation, we rank them in the bottom panel in terms of the cell surface LDL receptor expression that we could measure at the surface of those cells. And as you can see, even among those patients who carry the exact same mutation on the LDL receptor, there is a huge variation in terms of LDL receptor cell surface abundance. What we found is that the cell surface LDL receptor that we measure at the surface of the cells isolated from these patients correlated perfectly with the reduction in LDL cholesterol that was found in those very same patients following treatment with the PCSK9 inhibitor evolocumab. The correlation coefficient was 0.737. So, if you have a patient with FH, and in particular homozygote FH, it is extremely important to know what mutation on the LDL receptor is present in those patients. So it is very important to do a genetic test. It is even more important since last year because all the possible mutations that may exist in nature on the LDL receptor have been individually studied, and that seminal paper was published 6 months ago in Science by the group of Roth from the US, and they found that some of those mutations completely abolish LDL receptor expression and function. Some have mild or moderate effect. Some have a very detrimental effect on the LDL receptor expression as well as on its function, which is to internalize LDL. So the functional sequence map of the LDL receptor is now available, and it's only necessary to know which mutation is present in our homozygote FH patient on both alleles to determine whether these mutations are compatible with drugs such as statins and PCSK9 inhibitors that act through the LDL receptor. So what therapeutic options do we have? We have statins and ezetimibe, and probably in the future PCSK9 inhibitors in the form of oral pills. Current PCSK9 inhibitors that are prescribed are either monoclonal antibodies or siRNA or antisense oligonucleotides that need to be injected. And in the future, there will be also a one-time gene base editing treatment, which will require IV injection that will be performed by the healthcare provider. I just want to mention briefly enlicitide, which is a new PCSK9 inhibitor in form of an oral pill that works as well as monoclonal antibodies or siRNAs in terms of reducing LDL cholesterol. That has been released last year, and that was shown in heterozygote FH only. The last technology, gene addition, is still under development, but the first results indicate that it is extremely promising. It requires the intravenous infusion of lipid nanoparticles that carry the editing components, notably the target gene guide. The editing components are delivered to the liver via a technology that specifically targets this organ. In the liver, there will be an addition of the endogenous PCSK9 gene that is performed by this compound, resulting in the reduction of PCSK9 protein expression and hence secretion in the blood, with expected durable effects on LDL cholesterol levels. The first phase 1 results with this compound indicate that it can reduce LDL cholesterol in humans by up to 53%, which is in line with what the traditional PCSK9 inhibitors, whether they're oral, whether they're monoclonal antibodies or siRNA, do. So this is an extremely promising technology. You undergo the treatment and then it's done for the rest of the life of the patients. Again, inhibiting PCSK9 with gene therapy will only provide reductions in LDL cholesterol if there is some residual LDL receptor activity. For those homozygous FH patients with absolutely no LDL receptor expression or function, what is possible is to inhibit angiopoietin-like 3 using a monoclonal antibody, for example, evinacumab, that works well in homozygous FH patients by reducing LDL cholesterol by 47%. And using the gene therapy approach, Verve Therapeutics has demonstrated that inhibiting angiopoietin-like 3 would result in monkeys and non-human primates by a similar 46% reduction in LDL cholesterol levels in vivo. So in conclusion, if you want to develop a personal approach to treat a patient with homozygous FH, it is extremely important to know what is the affected gene and to do the genetics of those patients. Is it the LDL receptor? It will be in most cases, but it could also be ApoB, PCSK9, or the LDL receptor adapter protein. This is an important information to have. Now for patients, and that's going to be the vast majority with distinct LDL receptor defect, we have shown in vitro and ex vivo that they respond variably to statin and PCSK9 inhibitor treatment. The key is to know whether there is some residual LDL receptor activity in those patients. And for that instance, it is very important to know which mutation or mutations they carry on their LDL receptor. This is key to understand whether statin and PCSK9 inhibition therapies will work. If there is no LDL receptor whatsoever, these therapies, these drugs will have no significant effect. Finally, for those patients who totally lack the LDL receptor, angiopoietin-like 3 inhibition will be the key. This will be the key for those patients who are refractory to other treatments. And with that, I would like to thank the organizer for the invitation, as well as the companies and foundations that have funded my research. Thank you so much for your attention.
And with that, I would like to invite all the panel of speakers to shine up and open your cameras so that we can start the questions and answers. So myself and Dr. Tarak will alternate posing the questions between adults and pediatrics. And guys, I am a pediatrician, and I cannot resist not to thank everybody, especially IAS and GATE, for including pediatrics in such an important webinar. There is a scarcity of knowledge in our community as pediatric endocrinologists, and somebody like Nando is actually a rare breed in this community. So thank you very much for including pediatrics. And I would like to also thank Dr. Khalif by his closing statement, saying that it's a pediatric disease. So this is a testament of how important educating pediatricians about it. Okay, so I'm gonna head off with the first question, and then I will hand over to Tarek to alternate. So another very nice statement mentioned by Naji in his talk, and that goes very well with the very first question from the audience. So Naji said, let's move from incidental discovery of disease to protocol-driven. And I have a question, the first one for you, Nando's. Please, the first question says, tell us about the recommendations of universal lipid screening in children, particularly in the heterozygous, knowing that it is a fairly common disease. That's to you, Nando, please. Thank you.
Yes, well, this is a controversial topic, actually. There was a recent health economic analysis in the United States, which suggested that it wasn't cost effective to do screening for children, as had previously been recommended by the American Academy of Pediatrics, between 8 and 10 years of age. Now, this caused horror to many in the lipid world, because essentially that's saying children don't matter, children can have accelerated heart disease, we don't care about them till they're adults, and then when they're actually having, angina or myocardial infarction, then we'll get around to treating them then. That's cheaper than screening them in the first place to have prevented the disease. I think that's completely wrong and antithetical to anything that I regard as modern medicine. I think that's the idea that a lipid panel, which is a cheap test, can't be done in children because it costs too much. I think that's ridiculous. I mean, what child at some point does not have a blood test? How hard would it be to add a lipid panel at some point in their childhood? So, but that's the story. I think the health economics would be different in our region because, as we've discussed, the incidence of heterozygous FH is about 1 in 112 in the Gulf, so it's very high, at least twice as common as elsewhere, and that's obviously related to consanguinity. So I think it's a different risk-benefit equation, and I suppose along the lines that Dr. Naji was saying, I think you could follow the money, follow the cholesterol. You can actually start, each institution can look to see who are the patients we're missing already. So that's a simple thing, even if there isn't a formal screening program in our countries. So, we did this in Al Jalila and identified a significant number of children with very high LDL cholesterol. Sometimes there was an explanation, nephrotic syndrome or severe hypothyroidism, but often it was just, it's like no one had ever thought of it. You see an LDL of 360 and you do nothing. That's not really an appropriate response. So I guess start at home. That would be good. Start in your own institution, look at the database and see who's got a high cholesterol and how they're being managed. The pediatric world is relatively small as in terms of the number of cases that we would see. So I think it shouldn't be beyond us to do that, at least in our own institutions, as Dr. Naji did in his institution. So,
and I just furthering the discussion, and Dr. Nando is saying, Now, I did a very basic economical, just looking at some of the very basics. I'm not in the details. I'm not doing fancy. Just look at the numbers and just looking at the ICU admissions. So if we just look at that, so these patients, all of them, eventually, they all come back. They get admitted with very complex heart disease. And once they get admitted, maybe the first event could go fine with minimal, Second event is not fine. They stay, they have a complex surgery. Complex surgery is very difficult to treat, many hours, revisions, so forth. And then they stay in the ICU for months. And, recently, just looking at some of the numbers, millions and millions of reals, dollars, dirhams, it's a huge burden of disease. And it just, in our population, and those who follow these to the end, to the conclusion, what's going on, it's very, one patient is probably equivalent to screening millions of patients, just the cost of one patient event. Yeah.
Thank you. Tariq, do you want to ask the next question? Tariq?
Yes.
Okay, okay, over to you,
I don't know what
Tariq.
happened. I don't know whether you are seeing me. I can't see myself actually appearing my photo. I was reluctant actually to log off and log in because I had difficulty joining in anyway. I think I have just a sort of a query to Naji regarding your registry, because I remember, from all days past, there has been a lot of pioneering work into sort of rare diseases in Saudi. And that actually, was not only covering the indigenous, i.e. the Saudi natives, because the Gulf is a sort of a multi-ethnic, and there is a sort of a large multi-ethnic sort of admixture, in Saudi, likewise the rest of the Gulf countries. I don't know whether you had a chance of picking up any sort of homozygous familial hypercholesterolemia in the big sectors of the expats in Saudi.
So
you are muted.
Excellent question. Unfortunately, just the way the structure of the hospital is, it's a referral center from other hospitals in Saudi Arabia. So the patients who come to the hospital, the vast majority are Saudi nationals. We have maybe a couple of patients from Kuwait who also share their treatment in Kuwait and come and see us as well. But the problem is when you have a very rare disease, and these diseases tend to go, so not only are they in for Saudi Arabia, they are in a very specific location. Like 85% of patients who are within a certain geographic area in Saudi Arabia and certain tribes who are really consanguineous, have founder mutations, and they're really concentrated in this area in the north west of the country. But I have not seen patients who are expats who had homozygous. I have seen heterozygous, which were not included in the registry, but I have not treated homozygous. But as we screen more and do more genetic testing, some of them might show up.
Thank you very much. Thank you. Asma, I think you have got some questions. Yeah, in relation to the pediatrics.
I think, sure. Shall we do that after?
Yeah.
Shall we do that after hearing our chairman? I can see
All
Dr.
right, okay.
has his hand up. He has a priority here.
Yeah. Sorry. Thank you very much. To answer your question, Tariq, I did with Professor Faisal Allaf in Mecca, Al-Qura University. We did screen so many patients, and most of them, of course, are Saudis. And as Naji said, some tribes we can also elucidate on those tribes, and from this tribe, sub-tribes also. But for the expats, we got like 2 patients, homozygotes from Pakistan, and I referred them to Dr. Fawzia Sadiq. I gave her the novel mutation of those 2 patients, and I don't know what's happened thereafter.
Thank you very much. That's very enlightening. Okay, Asma, you quickly start with the few questions from the audience, from the delegates. Yeah.
Absolutely. I'm very happy to do that. So we have a collection of questions all about liver transplant. And I was delighted to hear from you, Naji, about the work that our colleagues Abdallah Leshwil and Afaf Saghir paper. Few questions. One of them is when to consider liver transplant, and this is for any of the speakers. And then, if there is a possibility to continue on evinacumab, will that be a replacement to liver transplant? And one question from a colleague in Pakistan who says, we don't have access to monoclonal antibodies and fancy medications. Can we jump into liver transplant? So 3 questions. When to consider liver transplant? Can liver transplant be delayed or even cancelled with the use of long-term evinacumab? And finally, if you don't have any of these fancy medications, will it be the first choice after failure of the baseline medications and statins? Choice is yours. Whoever wants to jump in with a question.
I'll start because I think it's a difficult question. Evinacumab and lomitapide are both incredibly expensive medications. So it's very hard to sustain that for any health system for a long period of time because we'd be talking lifelong therapy. And we don't truly know the long-term efficacy of either lomitapide, which only came along in 2012, or evinacumab, which came along in 2022. But at least in principle, they do seem to be highly effective. And it may be that it can reduce the atherosclerosis burden significantly, as I showed in the Japanese case. Now, if you're not able to access these medicines and you don't have lipid apheresis, what else can you do? I think the fundamental problem, at least from a pediatric standpoint, is, the median survival after liver transplant is something like 29 years. So, it's actually not probably as good as just leaving them alone if they're still young. But obviously, as time goes by and they accumulate cardiovascular risk, then so the cost benefit equation changes. But I think for example, we had a recent discussion that I was part of at Al Jalila Children's Hospital, we're no longer there, where we were discussing about 2 siblings, 6 months and 2 years. And, so if we put them up for liver transplant, Dr. Naji already showed us that, they can expect to live 37 years at least, even if we do nothing. So that's a pretty tough equation. Liver transplant is not so easy. And I've, having worked on a liver transplant unit in my life, it's not so much fun. But, obviously once you've gone through it and you've survived the acute phase, it gives you a good quality of life and certainly free of all that awful treatment burden of lipid apheresis and, severe fat-restricted diet with lomitapide and, monthly infusions with evinacumab. But my preference would be, given that there is effective medication, to really not to veer towards liver transplant unless it's simply the only option for that child.
From what age, Nandu, would you start evinacumab? From what age it's approved?
So evinacumab is approved from age 6 months. And, to be honest, most people with homozygous FH aren't even recognized, never mind recognized in pediatric age groups. But, But yes, if you pick it up early, you treat it early because the risk is so high. And even as we heard, children can die at a very young age from ischemic heart disease, sudden cardiac death. And unfortunately, around 30% of people who have a myocardial infarction, their first manifestation is sudden death. I think I've taken up a lot of time, so I better hand over to my fellow panelists.
So just one quick points. First, so perioperative mortality for liver transplant in our cohort. So about 2 patients had perioperative mortality, but those who survived, we have a median follow of 8 years, but some of them survived up to 15 years. They have some episodes of rejection that need to be followed up very closely. One patient actually developed new onset cardiovascular disease despite an LDL, significant LDL reduction. So we definitely, once you treat them with liver transplant, you have to understand that you will be ready to treat them with statins and probably PCSK inhibitors if needed be. So this is something I try to not leave them go. Sometimes just follow up with a liver transplant, never come back to me, and until they have a cardiovascular event. So that's something we have to keep in mind. But I think it's, in principle, a very effective treatment. It lowers the LDL significantly. There is at least up to 8 years out. Majority of patients are cardiovascular disease free or no recurrence. But of course, data for 26 years, that'll take time for us to get there. I think new medications are definitely promising, and I think as science goes by, we'll have an even better answer with gene therapy.
Right. I'm not sure whether, Fahad, are you raising your hand to make a comment or a question, or is that the old hand?
Unfortunately, we ran out.
No problem.
We ran out of time, so thank you very much indeed.
That's fine, no worries.
Because we had more audience questions than we had time to answer today. So thank you very much, everyone, for your participation in this excellent discussion. And if anyone is interested in rewatching this webinar or sharing it with your colleagues, the recording will be available on the IIS website in the few days. That is at athero.org. Okay, finally, I have one additional opportunity to share with the early to the mid-career physicians and researchers in the audiences that applications are now open for the 8th Wael Al-Mahmid and IIS Research Training Fellowship Program. This program is designed to support next generation leaders in the Middle East and Africa who are dedicated to advancing their clinical research and education in atherosclerosis and cardiocerebrometabolic disease. These fellowships come with a $10,000 award, and please scan the QR code on the screen for more information to apply. Can you see it? Yeah. Okay.
Yes.
Okay, great. Thanks again to Gen Pharm for their sponsorship of today's webinar, and to our co-hosting organizations, the Gulf Association of Endocrinology and Diabetes, Middle East and North Africa Pediatric Endocrinology and Diabetes Society, and the Saudi Heart Association Atherosclerosis Working Group. Thank you very much indeed, and good night all.